Welcome everybody to the Source webinar, AI in Aged Care, the Technology Forecast for 2030. This is a 1-hour webinar and we have an excellent panel of experts in the aged care sector and the IT sector. And we're going to be discussing for approximately 1 hour the opportunities and the challenges that AI present aged care and how we can deliver better services for our residents and our clients out in the home field. My name is Christopher Baynes, and I'm going to provide you with a slide presentation, just a quick introduction slide presentation. Heidi, if you could bring up the first page, please. Thank you very much. And if we could take the second page, please. Okay, so over the next hour, what we're going to discuss is what is AI, because there's a lot of confusion and there's a lot of speculation, especially with ChatGPT coming along. But we're going to keep it to the basics because it's a matter of what can make it work for you. So we're going to look at it from an aged care perspective today. We're also going to look at where is it needed. We've had a conversation with the panel before today, and realistically looked at how the aged care sector can be using AI and ChatGPT, and where are the priority areas that we should be looking at. And then we're also going to look at the blue sky and what is the potential, because it is seriously really exciting, but we also have to temper it with the realities of what is going to, the timeframes that AI is going to be properly realized and so on. I can have the next slide, please. So we looked at the priorities, and the group agreed that the priorities in aged care is really, when we're talking about artificial intelligence, the number one area where we have to apply it is staff support, because staff is such a major concern for the sector. The second area where they see it being of great use is going to be in the area of compliance, because all operators are struggling under the increasing compliance workload, and there's not going to be any change to that pace of new compliance. And the third area, further down the line, is clinical services, which is perhaps the area where many of the people are getting excited, but the panel feel that staff support, compliance, and then clinical services is the priorities that we should be looking at. We could have the next slide, please, Heidi. So just to assist us, I've put together some simple definitions. So what is the simple definition of AI? Because many of us forget what it is. So it's artificial intelligence combines computer science and robust data sets. That data sets is very important to enable problem solving. It also encompasses subfields of machine learning and deep learning. All the conversation in the media and so on since Christmas time has been around the natural language processing. But what is this? So the definition is that it is a form of AI that gives machines the ability to not just read, but to understand and interpret human language. So people are talking about the computer talking back to you and thinking like a human. With NLP, machines can make sense of written or spoken text and perform tasks including speech recognition, sentiment analysis, and automatic text summarization. So the things that have been concerning people in terms of privacy and what have you, and where are the machines taking, is that there is discussion that computers, AI, is developing emotional intelligence and can deliver contextual data presentations. So it means that for aged care, there is the opportunity sometime in the future that a human-like patient experience can occur at speed and scale. And it's those two last things, at speed and scale, that many people are getting really excited about, i.e. It will take away the laborious human elements of working in the aged care sector. We could have the next slide, please. Now, at the end of the presentation, Glen, Hegner, has been very kind to put together some reference material. And this is going to be sent out to everybody after the webinar, so you'll have material that you can go and refer to refresh or expand your knowledge. So if I could ask the panelists if they could now open their cameras, and we're going to have joining us with us Sarah Ramsey, Head of Aged Care Services at Fresh Hope Communities, Glen Hegner, Chief Information Officer at Fresh Hope Communities, Lee Martin, Chief Executive Officer at Tanunda Lutheran Home, Nina Combe, Chief Product Officer at Health Metrics. Welcome, everybody. And if I can start the process, I mentioned in that introduction that data sets is the most important component and that AI requires the data sets. Now, Nina, you're with Health Metrics. You're you're developing software systems to support aged care providers, and that also means that you have to be dealing with data sets. So can you give, from Health Metrics point of view, and you look at AI and data sets, could you just give an introduction of where you see AI today in its applications in the field?
Thanks, Chris. Look, when people discuss or think of AI, usually they tend to think of, right now, kind of the hype is ChatGPT, which if we simplify it enough, it's just a pre-trained transformer. But AI is much more, and for AI, it could be from remote monitoring, predictive analytics, robotic, voice or facial recognition. The technology are there and are great, right? But the use case of those can be limited to different sectors, right? If we look at the actual technology that we currently have, we can split those into two. Those that can address the current business challenges and support the sustainability of that business and directly impact the aged care providers. Those would be more of the predictive analytics, right? So those technologies, more the AI predictive analytics. And then you have the other technologies where that can deliver, an improved experience for either our residents or our users. And this is where, the chatbots like the ChatGPT can also help improve that experience. If we focus on the first point, which is the key technology, predictive analytics, the operators currently can utilize this to realize the business value from their data, by gaining actionable insight. And actionable insight is what we can do with all of this data. So eCase, for example, we hold a large pool of data right now. So we capture all of the data, whether it's operational, clinical, or financial. So you've got this amazing set of data that you have in your fingertips, but how do you take advantage of it? Using something like the predictive analytic AIs, you can begin to understand the data a bit better. So for clinical, let's say if we take an example from the clinical care and how we can use that in our predictive analytics, we can set to prevent, detect, and correct, similar to the role of aged care, the new model of aged care. With the prevent, we can train our data to look for things like risk falls, right? The detect, the actual AI can actually detect those falls. And the correct, this is where our human insight, we can go, all right, what can we do? Remove the triggers, remove these issues that are sitting and causing these falls. Back to your operation, we can use it in other areas like the staffing, but right now, AI is quite big, and if we look to use it properly, we can use it in our aged care, not at the GPT level, but more on the, let's say right now, the predictive analytic level.
In our discussions the other day, we identified that, so as you say, having access to data is vitally important and so on. You just mentioned things like sensors and movement detectors and what have you. Now, Lee mentioned as a one location operator in a regional area, the ability to invest in the equipment, the hardware to collect that data is extremely difficult. He also pointed out that, how many pieces of software can you have to link all this together? Do you want to overview that, Lee?
Yeah, thanks, Chris. Look, through my research, and I'm using numbers that have been made public, there's over 420 different pieces of software available to aged care providers to choose from. A lot of that software doesn't actually talk to each other. And dare I say it, every week there is more software added to the list. Our business here at Tanunda as a standalone medium facility with 120 beds. I currently use 30 different pieces of software to run our business. Not one bit of the software talks to each other. Only yesterday did I get access to Power BI, so I could now actually see my data from our clinical system, which is a real step forward. But as Chris indicated, it's the fact of affordability. For me to actually move forward with our IT system is going to need a huge investment from this company, and I'm not quite sure where the money comes from.
And Lee, you're not scared of technology, are you?
No, I'm not, because Tanunda's actually introduced robots. And so I've currently got 3 robots roaming around our facility doing back of house stuff and achieving great things with that. So I'm certainly not scared of technology, but it really does come down to, I've been very lucky in gaining grants that have made our current successes available. So I really do thank the federal government for their business improvement grant processes.
But your point is, AI sounds great if you can access the data. We have the challenge of having the historic legacy of having multiple, in your case, 30 different pieces of software. There is the need for them to be able to talk to each other, to be able to get that data. And therefore, you need really an operating system. The sector is going to have to move to operating systems that can interact. I'm assuming. So Glen, have you got a view on this? You're a large operator, you've got multiple locations and so on. How are you approaching this factor of software that doesn't talk to each other?
Yes, thanks, Chris. To Lee's point, yes, there's a lot of software that's out there, and it's really for operators and people on this webinar now. It's choosing the software and the stack. So we're predominantly a Microsoft stack. So then that enables you through Power BI, if you're able to ingest and get all that data, it lets you create those dashboards or those glasses of pane that can go and look left, look right, aggregate that data. And then it's also, for facilities out there to choose partners that are going to have their systems that have easy access to what they call an API, which means that you can export the data from my health metrics instance into something else to be able to get that data to use it in a safe manner and way. So I suppose it is choosing your technology stack is the key there. Is if you're gone down a road and you've got a lot of disparate sort of isolated software systems, to integrate all those into getting it as to what they call one pane of glass is quite hard. Where if you're selecting with a path or a partner that's already getting there and having open access to share that data, it's easy. So that's why we've kind of gone the Microsoft stack for our financial and our CRM, because they're all intertalking. I'm not doing an ad for Microsoft here. I'm not saying they're the best, but you've got to, if you choose a path, you've got to kind of do it. I suppose if you're a photographer, are you a Nikon or a Canon? Once you choose a path, you've got to kind of stick to it and then find the best ways that you can integrate those systems, because yes, the integrations can be sometimes more costly than the project you're trying to deliver a new system. So if you're delivering a new HR system and it doesn't talk to your other systems, the integration piece can actually be quite hefty. And then to the topic of today's discussion, AI, it's really, if you're giving it access to all this data, that's the power of AI, because through the data analytics, it can go and have a look at all these systems and then may work out why this is happening, or just point out anomalies to a real person to say, this is what I've detected, this is what I'm looking at. There might be some benefits in looking at this system or why this is happening here, or even finding out that certain months of the calendar that are busier for this site, or being able to do that analytics. But having someone employed to go through that data and go, find me something anomalous in all the data sets that we have, is not that. So I think the take home for providers is to make sure that your software stacks or your software as a service, as you are getting on all the new things, are going to be able to easily be able to integrate and potentially talk to one another. So you could aggregate it into something like Power BI. Now, when we say Microsoft Power BI, they're already down the road of making it easier, because with Power BI, it's a lot of click and dragging. It's able to go and analyze sets for you. It's not like you need a full-time developer to come in now and go and analyze all that data. It's giving you almost step-by-step instructions on how to go and connect this data and that data, if they've already got it, and then present it to you in a dashboard that's usable. And that's where, you know, there is a lot of hype in AI. And when we're talking ChatGPT, it's almost dropped as a bit of a name drop, and that's AI. Now, Microsoft has invested a heavily amount of money into ChatGPT, and they're ingesting that into their Office suite, and it's going to be called Microsoft Copilot. So the power of that is that you're going to be able to analyze your own data, your own meeting notes, and then get it to go and create Power BI apps for you to say, I want to know all of the data for people that are working weekends only, and ingest that data and do that way. And that's where we're going to be able to leverage some of that technology in a safe way. A warning to our panelists, to our webinar attendees, that there's a cybersecurity side as well with ChatGPT. It's an open platform. So there was a company that uploaded some of their proprietary data to get the code checked. That's now up there in the public forum. So the benefit of when Microsoft introduces that AI into your own Office 365 tenant, you'll be analyzing that data in your own structure, and it's not out there in the open public. So it's okay to ask ChatGPT some prompt questions about random events, but when you want to upload your data or your proprietary knowledge, you're basically putting that there on an open forum. So that would be just a warning when people are playing with ChatGPT.
We talked the other day about standardization, i.e. reducing the number of suppliers and the sector really identifying a smaller group of activities or suppliers, because they will be able to interact. And there is also the pressure perhaps of government increasingly wanting to have access to data. Where's your thinking on that, please, Glen?
Yes, obviously with the My Health Records, the government was interested in looking at some interoperability with providers and being able to share data. And I think there's some benefits there when you obviously maybe receiving a resident from a hospital transfer. You may have some information that may be quite helpful. But again, it's making sure that our vendors that we're using are able to have those correct mechanisms to share through an API that data, but also cleansing the data that's just sharing from a cybersecurity point of view. What sharing is being passed across, so it's just enough to know what's going on. We're currently working with Health Metrics with an API to another provider that's doing the survey tool to help us with this, the star rating function, doing those surveys, and it's able to export all of our resident names, so then we can easily do the survey that way. So they're the kind of integrations that we're looking at doing. But if the government, what would be good to have more government investment in that space and what they want, because I think the reporting requirements are unfortunately going to just really impact and affect our care staff in the time that they're spent actually caring for residents, rather than creating or looking at reports and generating reports to provide proof that we're matching the standards.
Sarah, you work with Glen. You're on the server side, you're at the coalface. To a degree, Glen is your support report too. He just mentioned the ability for data to be captured, e.g. the staff that worked weekends. Do you have the capacity in your day-to-day thinking to be able to blue sky and think, I could get this data? I mean, most people I speak to in your role, you're working 24/7 and just keeping the lights on and the staff engaged.
Look, I think that the possibilities are really exciting, exactly for you know, the issues that you say, Chris, you know, there's lots of questions that managers would like to ask of the data to be able to, you know, ultimately provide better care, but also support our staff in more meaningful ways. And to be able to actually pull those various pieces of data together, you know, at the moment we're needing to stay on top of, you know, our care minutes, you know, so they're obviously then related to our rosters, being able to then actually have some predictive analytics coming out of our care systems to indicate something that the clinical staff might need to pay more attention to. We know that everybody is incredibly stretched. And so to actually take, I guess, that top layer thinking out, where it's actually just identifying what do I need to focus on. You know, I see that there's huge potential in being able to, rather than present someone with a plethora of data and then they've got to do the matching and, you know, drill down into the report to see, well, what was the time that this was happening, and then look at their roster and say, well, who was actually on, to be able to start getting those pieces of data just to actually talk to one another so that you can ask, you know, some more meaningful questions, and put your resources and, you know, the power of people being able to do that high level analytical thinking, being able to engage with the residents. They can actually be spending their time doing those things that only a person can do, rather than having to look at different data sets and try and match and make a decision. So I think that both from the staff who are delivering the frontline services up to managers who are trying to make business decisions that ultimately are about delivering high quality care and meeting all of their regulatory and compliance requirements, I think there's great potential across all areas to really simplify the work in a way that allows people to focus their time on the things that are going to actually make a difference.
It's interesting, isn't it? There is opportunity, but it's almost too much opportunity, isn't there? The way I see it is the sector needs to be like a cooperative. So Glen just mentioned the working with health metrics for the star ratings and identifying the residents. So Glen's contributed that idea and that's being built, but that should now be to the benefit of all other operators. That becomes part of an established ecosystem in the sector, but then it requires people to, again, concentrate into these main operating systems. Would you and Glen feel that that's the best way to go?
I'll take that one, Sarah.
Okay.
Yeah, I mean, that's the benefit. So when we're particularly in the aged care sector, we've only got a small number of vendors that are providing our finance and operations or our clinical data systems. So being able to, you know, work with a partner and basically improve that system for the better good of that, there's benefits there for other providers that are then using that ecosystem. Of course, we'd want some, you know, some competitors in that market. We wouldn't want to, you know, you need that competitor to sort of, you know, iron sharpens irons to get the best things. But having vendors out there that are then, you know, working on those benefits and the changes and, you know, having those reviews and getting that feedback from, you know, the people who are using the systems to say, hey, in the next roadmap, what would this look like if we're able to do this, if it was able to maybe provide some of that analytic alerts and what it can do and how does that look? Because that's the thing with AI, it's expensive and it's getting someone to actually sit there and program it, work it out, program that, and that's the investment piece. And as an industry, if we were working with several partner vendors and we were all putting forward, we're all paying, you know, a 10% share in that rather than having to do 100% development in that space. And that's where you see the only advancements in AI is where you are getting that funding space to, you know, to be able to get the benefits.
Glen, you used the expression the hype cycle about the ChatGPT could bring to us. I'm going to jump because we received a couple of questions from viewers, and this goes to, and it might be an opportunity to talk about a bit of blue sky and also go to what Sarah was saying about supporting the staff. The question was, my introduction mentioned the removal of the laborious human element of aged care. A significant portion of the nursing workforce draw job satisfaction from this human contact portion of their role. What do you see the impact of AI being on retention of the aged care nursing workforce, and how can this be managed? So the question goes to staff enjoy the interaction with residents. Are they going to lose that as a result of AI? The alternative could be that could increase. Sarah?
My view and my hope certainly would be that it actually would be able to increase, because some of the time where currently clinicians are either entering data or reviewing data to determine then where to actually put, their time and focus. If you take some of that out of the equation and can actually, these systems could then actually present them with, this is, based on the predictive analytics and data coming through, these are the changes we're seeing in the residents, and we think that these are the people that you need to, go and do a clinical review, have a chat with. I actually see the opportunity for that human interaction, and those are the things that really make a difference, for the staff in terms of their satisfaction and engagement, as well as for residents. So, as I said, certainly my hope would be, and I think it's certainly possible, that those things would actually increase.
We talked of a couple of examples where the workload of the on-the-floor staff can be reduced. Now, Lee, would you like to tell us your thoughts on the challenge for RNs getting how many, what did you call it? Shitty questions?
If I could just go back a little bit. Firstly, the whole workforce of aged care is predominantly female, predominantly aging, and so we are having to think outside the square about where we're going to get our workforce from. Tanunda Lutheran Home has introduced robots to reduce the heavy load of laborious tasks of pushing trolleys. That gives our carers more time to do what they need to do with their residents. But as Chris has just alluded to, the role of the registered nurse, primarily in smaller aged care facilities that have large number of residents, is so packed with so many tasks that you sometimes wonder how the registered nurses last. And it really comes down to how can we reduce that? And shitty questions, the number of phone calls that come through to a registered nurse about, can I have permission to not turn up for work tomorrow, or Mrs. Smith hasn't had a bowels open, or whatever, coming from either external or internal in the facility. There's got to be another way of dealing with those sorts of things and allowing our very expensive registered nurses to concentrate on what they need to concentrate on, and that is the clinical care and support to the residents. I firmly believe that there will be robotics in the future that will have a capacity to do minor clinical tasks, such as supervision, taking a temperature, pulse, respiration, blood pressure, using facial recognition, using pain check with facial recognition, looking after security and so forth of your facility, and just reporting it all on a big screen in front of a registered nurse or a technician in the nursing station, and those who need immediate support would have a staff member go and give that hands-on support. I don't believe robots will take away the role of staff in an aged care service, but let's cut to the chase. We don't have a lot of staff in aged care, and they're all getting older and retiring.
Thank you, Lee. Going to the question concerning freeing up staff and your concern about the RNs receiving a multitude of unnecessary questions, and can there be an interface that answers those questions rather than the RN? Now, all the documentation around ChatGPT and AI is that it will develop the ability to have human interaction that is empathetic and a positive experience. So, for instance, receiving those phone calls from the family asking whether mum has had a bowel movement, that could be handled by an AI response, which could identify that it is the daughter, and it would have a totally different tone and response if it was the GP that was calling with the same question. So that would not be that would be actually freeing up the staff to have more time with their residents. Another example that we discussed the other day was the ability for the staff to be able to do their roster notes verbally, and for the system to be able to, they could just verbally give it, and also the system would verify that there are areas that they haven't completed or that aren't appropriate for the compliance record, that the AI would correct that, and again that would free up the staff. Sarah, does that agree with where you think the freeing up of staff can go?
Potentially, yeah. I think that anything that looks at the interface between staff and residents requires some co-design, so that residents are involved in that piece as well, because whilst, yeah, absolutely, there's opportunity to remove some of those tasks that are not resident facing. Yeah, I wouldn't want it to be, at the cost of, I guess, the relationship side of things. Yeah, but I think that certainly there is opportunity there. Yeah.
Okay, well, the questions are coming in. Does anybody wish to add to that? Sorry. Glen?
Yeah, I do actually, Chris. I've just been scanning the questions as well. Some great questions there. Thanks, everyone. And there are some questions around, like even with Microsoft Copilot, can it, create some subtext? One of our doctors, interestingly enough, he's in his 70s. One of our sites, he actually has a whole lot of predetermined text that he then just edits and changes. So, again, working with our vendor partners, that it may suggest certain case notes and stuff. That's where we're going to get some of the benefits. That's going to save some time. We have, sometimes our employees, English is not their first language. So, having things that could then help assist with spelling or suggested notes, even, text to voice, which is getting a lot better. And in that space, that's the most commonly area where AI is being used today, is in chatbots. And, they're able to take a video like this that'll be out there in the public and get our words and then create a virtual avatar and then reply back. So that technology is getting better. That's been a lot, but again, that's where the investment's been, because companies are using that to replace call centers to do that auto answer. You ring a restaurant, they're going to ask you what time and stuff like that. So that's where that could be a piece where you're freeing up staff time. But again, that's the significant investment piece that needs to happen with the vendors that you're working on. And then there'll be privacy issues there. So how do you verify that, Glen is ringing up to ask how mum's going today and what was the result, the latest results? How do you verify that, that's Glen actually getting the right results, so we're not breaching privacy? So that's where I think there's a bit of integration piece, but some of the stuff that's out there now can be used in a safe way to basically assist and save time for our care staff.
So
I can just add to that, Glenn. Just taking on like predefined text. With eCase, we identifying in, let's say, the app, like the workforce on the ground, that English is not their first language, and they might not understand to go and type a progress note that's 10 pages long. You can put those predetermined text as a setup. Right now it's as a setup, but moving forward they could be used by voice recognition, and instead of having to type or to understand the predetermined text that they need to actually input, they can just say, hey, I've done this task, can you please add this note that correlates with that task. So still having that facing, that workforce facing the actual client and doing the work, but that data entry that needs to go along that action that can be done by AI, by smarts, that you don't have to actually type and enter all of that data. It can be done as you're actually doing the actual task itself.
Thank you for that, Nina. Glenn, you mentioned the Microsoft Copilot question. I might read that out for the audience, if you might be able to address this. One of the current concerns with Microsoft Copilot is that if everyone starts using Copilot to summarize the emails they receive instead of reading them in full, and then getting Copilot to automatically generate and send a response for them, will we get stuck in a loop of AI running the show and humans just hoping AI gets it correct?
Exactly. I think some of the comedians have already done this, where they were using ChatGPT to talk to their significant partner and send them messages, and all of a sudden they were getting comments on how wonderful their partner was being responsive. And then when they asked the deeper question, oh, but you said this the other day, they weren't able to do that. So yeah, I think what you're seeing already with Microsoft, it's just doing, you read the message and it's getting it back already going, well, thanks, that's great. So it is just saving you doing that last little bit. You can already predetermine and put your own text in, that you could just write a keyword and say thanks, and then it will write what you would normally say. But yeah, that is a real danger, where we're going to be just sort of glossing over everything and skipping our way through, because AI is doing that. It will make us dumber. I mean, look, when Google goes down, we're all of a sudden not smarter because we can't search something, because we're so used to it at our fingertips, that you can just, oh, I don't know that. What's the weather in Melbourne today? I'll just go Google that. We're all of a sudden going to lose that ability if we rely on it too much. So I suppose it's again making sure that we keep a grip of what's actually time saving, but what could be in our industry medically dangerous, because I'm just cutting and pasting notes, or I'm not identifying what is really going on here.
That goes to a very important thing. I was wanting to ask you, Glenn, later, but I'll ask you now. What is the time frame that you see change relative to AI? Is it a creeping change, or is it going to be a fast change? So is it 1 year from now we're going to be having the same conversations because of concern of risk, or are we're just going to take that risk and accept it and we'll leap forward, etc.?
I came from education and government, and I've been in the aged care sector now for 6 years. And that's why I linked some of that resource slide at the end. There's some old reports there from McKinsey from 2020. There's one from Monash University in 2020. Back then it was all, oh, this will be happening and we'll be having this and doing that. None of it's happened. So I think there's a big danger there that there's a hype that this will be replaced. The only driver that's going to change this will be the investment. So again, whether we band together and we combine to go, let's go out to a vendor to develop this specific system that may work for us. If we're able to do that as an industry, that would be pretty exciting, because we could then, drive the benefits of what are the business requirements that we're trying to solve, what do we want AI to do for us, and then that will benefit our smaller providers to larger providers, because we're all lifting the share. But at the moment, we're all driving it in different ways. It's not till you are with a larger vendor and they're willing to have those roadmap meetings with you and able to receive your input and share what you're wanting to do. And we're able to do that now with our current vendors. But if we were looking at a real change where we think AI can do that today, we would need that investment. So today you can get a security system. I'll give you two examples. So security systems already today can look at you and do facial recognition, right? Glen's a dementia patient. He's heading for the door. He's broken this barrier. Send an alert to their care staff. We hear all these wonderful things, but who's been able to implement it successfully yet? Because it's quite expensive to implement and we've got other priorities on the list. I'm in IT, so Wi-Fi. We keep hearing about Wi-Fi tags and we can basically, put a pendant on a resident or sew some RFD stuff into their clothes, and then the same thing, we can track or work out where they're going. It's a little bit faulty because they're not wearing, might not be wearing that jumper today that we sewed the tag into, or where's equipment lost. So it's got benefits and it's got that blue sky. Yes, we could do this, but it hasn't really nutted in. I think one of the interesting things one of the vendors were looking at doing was when we were all hit with COVID and talking about saving staff, someone was there at the front door. Have you been overseas? Have you traveled? Have you had any symptoms? It was able to do that through like a virtual assistant that sat there and then was able to look at, your temperature, ask you all the questions and record all that. But again, some of those systems are probably more expensive than maybe getting another staff member at the moment. So I think if we're looking at any real change in the AI space, it would be a conglomerate of all of us getting together to say, what are the real challenges in this space? What could AI do, and what vendor partners could come together to, have some R&D and development time to maybe develop something that would work for us.
So again, if I ask a time scale, would you say in 3 years' time, we will start seeing some significant benefits that will flow to our three priorities being staff, compliance, and clinical?
I think there'll be, in the next 3 to 5 years, there'll be definitely some changes that we'll be able to use. And again, it's just confusing, the question with AI as official intelligence, but it's basically data sets that have been programmed to analyze, if this happens, this is what this means, or being able to provide that information quicker. So if that development time spent, that could be the next 3 to 5 years with a lot of the programs and doing compliance and looking at what we're doing or how we can, better save staff time from doing the menial, tasks that they're doing that could be literally handed to a program or system that could look at that and analyze that data and then give it to them. But you can't remove the human piece. You'd still need to do that analyzing bit at the end, so you're not totally got your hands off, and that you're back in control to see what that means. So I think that was the, also in the note sheets at the end, there's a great podcast from the CSIRO on AI, and that episode 3 was talking to one of the doctors or radiologists who developed the AI to look at scanning breast scans and to working out that technology there. And her main point, Dr. Helen Fraser's her name, she was pointing out that 95% of all the scans, there's nothing to see, but the AI would help, reducing that limit to look at the 5% of that, and then pointing their clinicians to look at the right ones, or the radiologists at the right ones. But they found that there was mistakes, so they could not remove the human element. So it wasn't a replacement. It was just actively acting positively to help assist them to make sure that they could focus their time deeper on the ones that they needed to look at.
Thank you for that. Nina, you're at the coalface, i.e. the investment in the development that Glen was talking about. So what is a Health Metrics approach to the opportunities and your development programs?
Yeah, so thanks, Chris. So what we're finding right now for us, again, because we already have the data set, is what we do with that data set and how could we make use and ensure that our providers can ensure that access to that data set is cost effective. Our roadmap looks at looking at prioritizing all the predictive analytics, the ones that I was speaking about earlier on. So our focus is more on, obviously not robotics or anything like that, because we're not in that space, but we are more in the space of similar how Glen was talking about Power BI and how he uses the Power BI and Microsoft. We also use, predictive analytics, but, using Yellowfin. we're looking how we can actually making those dashboard kind of easier, automated, and flowing that back into a task-orientated information. So, you know, all of our dashboard, we will invest a lot in that to consume and understand the trends and to reflect back to the user to actually do the actionable insights. So all of the investment will be on ensuring all of the predictive analytics is there for someone to use it, as well as, you know, that disparity of the data. Right now, everyone has their own set of data and there's no connection. We are also ensuring that moving away from that silo and, you know, opening up to the My Health record, opening up to all of the APIs. So everyone in the sector has a proper one place that can, you know, have a 360 view, if you may. So, you know, understanding that there's a lot of, you know, investment requirement, our investment would be into that, to ensuring at least we are looking at solving one of these areas, which is, you know, actionable insight and how those insights can help you.
So again, it goes to what Glen was saying in terms of it's requiring investment. So
it does. It's either through the sector, through privately, through whatever, like everything requires, you know, us, you know, ensuring, okay, we need to solve this problem. How do we solve it? We obviously need funding to solve it, which we will focus that funding towards that.
So the blue sky is a long way away, but it just requires the investment to get there. We have a question relating to large language models. The use of large language model to respond to questions or requests from consumers and their carers' families sounds like it could alleviate significant workload from already stretched RNs. Where does the burden of risk fall in regards to legislative requirements around clinical decision-making? Where do you draw the line on what AI can do and when clinical staff should intervene? Sarah, have you got a view on this as you're at the coalface of the clinical?
I think that, well, you know, essentially the law is usually a bit of a lag indicator on things, you know, particularly with technology. And it would come down to, again, you know, some of that co-design piece and who key stakeholders would actually be in developing some of that, what kinds of questions. I mean, I would certainly, you know, at this point, not be looking to replace clinical discussions. You know, it would be sort of basic information that you could look at providing to people, but actual discussions, you know, because still that's where you get that human factor. There's lots of nuanced things that come out in a discussion that actually impact care that may not, well, that won't come out if it's essentially a one-way, you know, communication of information. Yeah, so I think that there is a long way to go in that piece. Where I would see more some of the benefit is in terms of, you know, care staff and RNs also, you know, being able to get some quick, you know, answers and assistance in their own decision making, so that then they can actually be providing better information to families and actually assisting families in that decision making process with, yeah, better information. But I think at this point, yes, from a risk perspective, yeah, it's not something I'd be willing to play with. Others may have a different view. Lee, well, I don't know what your thoughts are on that.
Again, perhaps it goes to Glen saying, you know, the hype cycle. Are we all being naive? Go back to the very beginning. AI only works if the data is there. So in what you're just outlining then, Sarah, all those answers, the clinical answers that also have to have empathy in them, that has to be created as data sets, doesn't it? So are you planning to spend weekends writing all those data sets so that the computer can refer to them, or not?
I would honestly say it's not my number one priority right at the moment.
And that is,
but again, being able to have better predictive analytics so that clinicians can make faster, better decisions and then contact the family with, this is what's happening, this is what we're seeing, this is what I'm thinking, and get the family input to actually speed up those processes. I think that's a much, shorter term benefit that we will be able to see.
Glen, is that what you're seeing as well? Is that data has to be created, those human capsules?
Yeah, look, I'd be totally scared that we were taking the human touch out of it. But what we could do to assist is that, like we've got CRM systems now. What happened if that CRM system told our wonderful RN staff that there was a family history there, that when they may be talking to the family, they may need to know that, mum and, their brother or someone passed away from this, this clinical episode as well or something. So then you're getting that empathy and you're getting understanding, or that, they've got another relative in another facility somewhere else. So it's that linkage of data, just so when the staff are, contacting or talking, they've got all these other touch points of data that may help them relate and share more empathy, and even, be able to provide some scripting on what, comforting things to say, but not replacing the human, but saying these are the sort of things that might be aware that, because if there's a family history there and there was just a recent, they lost mum the week before and now dad's just passed away, that's all great intel that you would want to know as a clinician before you're talking to someone, so you get that data.
But who's going to design that data set that says this is the information that will be useful to have?
Well, the good news is there that if you do have a CRM system now, so they're the sort of engagement tools that you can start then getting that data, but it'll be then, being able to look up and someone sort of looking at is that data meaningful? So I don't think there's some easy ways and there's some harder ways to do that. But I think it's more taking that time on getting that, that intel first, if you wanted to look into that, if you're, happy to, do it raw. But if the system, or you could easily go, let's look up this family name and what's the history? What do we have there? That we could then know that we're going into that call or that difficult conversation armed with the right information. But there could be prompts in systems that would, be able to share that as well. So again, it's the investment piece, and it's someone deciding what bit of AI or what bit of business system do we really want to solve that is actually going to be the best bang for buck to free up our care staff to have more time on the floor. And some of this is not bang for buck.
And going back to the question, they're asking specifically around the legislative requirements. So in creating those data sets, somebody's got to have a keen understanding of legal obligations.
Yeah, well, so with the Australian personal identifiable data, we're responsible to make sure that we are securing that data and that we are not sharing that out, or that data is getting away. And that's to put my cybersecurity hat on, that's kind of where the Optus hack, we were all kind of outraged with all of our information, our driver's licenses and everything, being available. And essentially that wasn't a hack. That was an open API system that was just discovered, and someone went, oh, I'm challenging this system, and it gave them back all that data. So that's the worry for us when we're legislating or looking at all these systems, that we're actually testing and protecting them, that we're not leaking out data that will cause an issue or will cause hurt and harm to a family.
I see it as a minefield. So using your example of, the brother passed away, it could be that some members of the family don't want that mentioned.
Yes, yeah.
So yes, a minefield for that questioner. There are a number of questions for Lee around robots, so I'll try and combine them. My question for Lee Martin. Hi, Lee. In your opinion, would the introduction of robots in the care realm increase the loneliness issues, or would it be balanced by staff having more time to spend with residents and certainly not lose jobs to robots? And there was a second one concerning robots. How do we get residents and families to trust AI and robots, especially when the elderly are frail and even sick?
Yeah. Let me start by letting people know that robotics throughout Asia and Europe is very common. There's currently clinical robots being installed in hospitals in Hong Kong, and Singapore are about to receive clinical robots as well. One of those clinical robots has actually been imported here to, and it's in Adelaide, and hopefully that robot will be tried and tested out here at Tanunda Lutheran Home. So to try and combine the question about the use of robots and the acceptance by staff and residents, it's all about the implementation process. We involved our residents and staff right from the word go about robots. And when the robots arrived and when they sort of were able to start transitioning through our long corridors, we actually had a competition to name our robots. So we have Robbie, Axel and Speckle, the robots. We then had our Lutheran chaplain actually go through a naming ceremony, which staff and residents and politicians attended. So what we now find is that residents and staff are actually talking to our robots. So they do become part of the family, because residents and staff do recognise that the robots are there doing a job. They are doing a job that are making the staff safer and giving the staff time to spend doing what staff do best, and that is talk to the residents. So there are so many sensors on a robot. A robot can't run over a resident. The robots are very, very polite, that if a resident or a piece of equipment or whatever comes in within QE of a robot, it will stop, wait until the obstruction moves on, and then the robot continues going. Our robots do talk, as in the robot, if it's going around a blind corner, will actually say, robot entering area, please be careful. And so, again, our residents are really enjoying that sort of thing. I actually firmly believe that robots will become the support service to our clinical, particularly the registered nurses, and the AI in robotics is just developing so quickly. It's going to be like the mobile telephone. You know, we didn't think the mobile telephone would ever go from that large battery thing to what we've got now. Well, there's robots out there that are, you know, even since I've had robots here, the technology and the size of the robots and the ability of the robots has increased no end. And the good part is the cost of the robots has reduced dramatically. So obviously, the more people using robots, the less the cost.
We're coming to the end of our time. So a quick answer, Lee, same question I asked Glen then, for those interested in robots, what time frame do you see? Is it 1 year, 3 years, 5 years before they're accepted as not a mainstream, but the early adapters have taken it up?
I would say 2 to 3, and Tanunda Lutheran Home is at the forefront of that. So if anybody on there wants to come and see robots in use in the aged care sector, feel free to come and see us. There are about 4 other aged care services using robots, but maybe not in the same way that we are, as in our robots actually travel down the same corridors that our residents and staff walk. So they are intermingled with our whole operational process.
Well, that's exciting in its own right. So we've come to the end of our time. I ask if there's any of the panelists that would like to make any particular points before I finish up. No. I think what it has, when we started looking at AI for a webinar subject, there was all the enthusiasm for the future, the blue sky. But when we sat down and discussed it, the realities of which is so typical of the aged care sector, we all had to stop and think about what the actual tasks are done each day, not only in residential aged care homes, but in the home care sector as well, and the monumental challenges. So I can just remind, at the beginning, we said that the panel identified that the #1 priority, and where they're keen to see AI come to fruition, is with staff support. Following that was compliance, assisting in compliance support, and finally in the clinical. And they're seeing the clinical, maybe because of these legal ramifications, also building the data sets around clinical, as being some time off. So can I thank our panel for their contributions today and giving their time. And I hope that you have found this beneficial. We will be sending out the slide deck, which has those links which Glen provided. And particularly he's recommending episode 3 of the CSIRO link because it relates to health. And I hope you found this a beneficial 1 hour of your time. Thank you very much, panelists, and greatly appreciate it.